On Channel Africa, nothing but the good stuff and the African perspective.
21 after 4 on Channel Africa with Poppy and Ntsako. We're having a conversation right now about the advances in reproductive medicine. This is a chat that's close to my heart because the world is changing in terms of how people are starting and building their families. There's IVF, surrogacy, and donor conception. And to chat to us this afternoon about these processes, we have Dr. Kasturi Moodley, who's an obstetrician and gynaecologist at Mediclinic Southern Africa. Good afternoon, Doc.
Hi, how are you?
So good. Doctor, I have a quick question regarding trends when it comes to reproductive medicine. There's a journalist by the name of Aisha Sase who conceived a baby via donor conception. And she was talking recently about how, you know, the stigma around just kind of deciding that you want to have a baby and a baby on your own is now what she's having to face now that the child is in the world. What are the trends and what is common from an African or even Southern African perspective when it comes to IVF, surrogacy, and donor conception? What are we seeing more of?
I think there's still a stigma around it. I think it's still shrouded in a little bit of secrecy, in a little bit of embarrassment, a little bit of so-called controversy. But I think we have moved in leaps and bounds. Our experience here at the Midlands Fertility Health Centre at Mediclinic PMB has been quite pleasantly surprising in that people are much more open to the suggestion of these options if that is what is necessary for them to have a baby, than we actually predicted or saw previously. So I think their religious, their social beliefs, they've actually pushed out of the way, and that their need and desire to have a baby and start a family has superseded actually all these stigmas. So that has been extremely exciting and extremely fantastic to watch as the years have gone by.
Doc, you know what's so interesting about what you're saying now, and even with what Poppy is alluding to, is the fact that there are so many different scenarios where IVF and different ways of conceiving can be, you know, considered. I mean, for example, you have women who struggle with endometriosis where each day it is progressing. At what point do people or couples start to be concerned about their manner of conceiving? You know, is it after how many failed tries should you be wondering whether we should try alternative ways to conceive?
So I think even before we get to the actual definition of when should you seek fertility assistance, this is why a general gynae visit yearly is so important, is that every female from the time she starts menstruating for her entire life should actually see a gynecologist once a year, because then your general gynecological health, your plans for the future, whatever medications are instituted, their effects, when do you stop, what to expect, and when to communicate with the different facets of our expertise, I think can all be addressed even prior you even consider starting. So that's the first point that needs to. I think people often think, I need to go to a gynae when I have a problem. No, ideally, you should go when you don't have a problem, so you continue to not have a problem. And so I think by definition, any female who is younger than 35, who's been trying with her partner with unprotected intercourse for 1 year, 12 months, should ideally go through to a fertility center for further investigation and treatment. And those women who are over the age of 35 should ideally seek assistance within 6 months.
Dr. Moodley, can you explain the difference between IVF and IUI?
So basically, when a couple come through, they are having baseline tests, and those baseline tests involve bloods that look at a person's ovarian reserve potential to release a good enough egg based on their age. Then they get a fallopian tube test, because fallopian tubes are not visible on an ultrasound. So we do a specific test to determine the patency of a tube to allow egg and sperm to meet, to allow an embryo to travel back into the uterus. And then we do a semen analysis. So that's essentially a baseline. In up to 60% of our patients, you find that all these tests come back normal, but they fulfill the criteria for infertility. So they've been trying and they've not been successful. So essentially what it means is that there's most likely a microscopic problem and not a macroscopic one that is visible to us. For that couple, the simple, least invasive fertility treatment called IUI is done. Essentially what we are doing within a 14-day period, mimicking the menstrual cycle from day 1 to day 14. We would give medication that is in a dose at a higher level than the brain's hormones in an attempt to recruit a better quality follicle to get a better quality egg that will get released into the fallopian tube and time the release of that egg, and then take a sperm sample, wash it down to get the best of the best and inject it directly into the uterus. So that is IUI. We're still reliant on the fallopian tube to for the egg and sperm to meet, and then we're reliant on it to transport the embryo into the uterus. IVF is now a step further. Patients who, for example, are a bit older, their egg reserve is diminished, there may be a minor problem with sperm, or both fallopian tubes are damaged, like, for example, patients with endometriosis, etc., etc. We are then essentially performing all the procedures outside of the body. We stimulate the patient for 14 days. We get as many follicles to grow. We then take her into a theater setting, retrieve eggs. So now we have eggs in the laboratory. We get a sperm sample. We fertilize the eggs in the laboratory, get embryos in the laboratory, and then we transfer a suitable embryo into a patient's uterus. And whatever remaining, we are able to freeze. And that's how we can then thaw out and use an embryo at a later stage for that individual.
So what are some of the lifestyle factors that we do not pay attention to that could affect both processes?
Basically everything. Everything we do in our daily lives. So what you eat and what you drink, your alcohol consumption, smoking, vaping, drug use. And when I say drugs, I mean recreational drugs, as well as steroids in a gym capacity, our stress levels, our lack of exercise, our lack of managing our stress appropriately. Every one of these factors has a contributory factor to the maintaining of a finite follicular pool that results in the egg quality as well as sperm quality.
Doc, do you mind